Okay, we'll have panelists come up, and we were going to antiretroviral therapy cases, which we've done before. And feel free to ask questions as we go, and I'll try to get those incorporated and merge the Q&A with the actual presentation. A lot of these cases are questions that I collect over the course of a year and then synthesize them into some hypothetical or stylized case is probably a better word to say, is to keep it straightforward. And they're all around questions that we encounter in practice. So we have a similar cast of characters that we had yesterday for the panel. Some people have switched positions, which is okay, just to kind of keep you honest. So we'll go ahead and get started with the first slide. How about the second slide? Okay, that is the second slide. Great. So we're going to talk about starting therapy, weight gain, go a little bit deeper than what Dr. Badimo just did. I don't understand the reference to short people, but I'll figure that out. Treatment on pre-exposure prophylaxis, failure regimens, persistent treatment failure on R discordant CD4, and difficult to treat OIs. So here we go. What should we use as initial infection for initial diagnosis? A 48-year-old man initially diagnosed, viral load is 280, CD4 count 65, other labs are normal, genotype is wild type, no prior medical history, normal renal function. He's okay to start therapy if you want. Here are your choices. Let's go ahead and vote and see what kind of crazy music we get.
I think you have to come up with your own music.
We don't get any crazy music.
I'm sure you have music.
Okay, I'm going to watch, like Dr. Gallam, I'm going to watch for numbers of voters. We'd be here for a while. Okay. All right. So most people went with fixed dose combination. Some people went with 3-TC dolutegravir. We'll talk about that. Some people wanted to go direct to inject, not many though. Dr. Gulick, you are a director, leader of the HHS guidelines. What do you say, ye?
Ye say that the top three choices here are the top three choices in the guidelines. So good to see. The bictegravir regimen was most popular in the room. Certainly one of the first line regimens that we might use. It's one pill once a day. Dolutegravir 3-TC also recommended first line in the guidelines, one pill once a day. And then the third choice is one of the tenafavirs and 3-TC or FTC with dolutegravir. That has to be 2 pills once a day, so I assume that's why that was a less popular choice. But all those 3 choices are recommended in guidelines today, not just in the US, but actually in Europe, Dr.
Yes.
Badimo.
Europe. So let me dig a little deeper with you, Tripp. Let's say the viral load at baseline was 890,000. Does that change your opinion on dolutegravir 3-TC, or has that been debunked by now?
So the guidelines do say if a viral load is above 500,000 that we should not use that regimen. Roger just presented some early pilot data to suggest that you could use it at higher viral load levels. I would be concerned about doing that at this point. There's pretty good data from switching to a 3-drug to a 2-drug regimen, including dolutegravir 3-TC. So if we had that idea that we wanted to go down to 2 drugs later, maybe start with 3 and then switch to 2 later after the viral load is decreased some.
Okay. Dr. Badimo, what would you say if the hepatitis B surface antigen was positive?
Yeah, then I will go with the 84%.
So you would not go with dolutegravir 3TC?
No. I think that it's still something that we need to be mindful of, even if the proportion of people with HIV in the U.S. with hepatitis B infection is not it's not as high as elsewhere, but it will really not make any sense to. Even the Alliance study has really reinforced to us that TAF FTC would be great in people with co-infection.
So one of the reasons we don't typically just go start with dolutegravir 3TC right off the bat is oftentimes we don't have a full lab panel back. So we usually go with the 3-drug regimen, and then Dr. Gulick, as you said, we might revert to a 2-drug regimen then just for simplicity in some degree. Dr. Chu, you're at your National Reference Center in San Francisco, and you get a call from somebody who says, I've started somebody on BIC-TAF FTC. I'd like to switch them to dolutegravir 3TC, but I just got the antibody, the hepatitis B status back, and everything's negative except the core antibody is positive. Next question. How do you manage that?
You chose the one topic that we still have a lot of very lively internal discussions at the NCCC about. So I think that practice has been shifting. I know that like many people might have sort of reflexively wanted to get that HPV DNA, and I think probably some people still do it at times. But I think what you need to do is sort of step back, look at all the serologies, look at some of the clinical history, try and see if there's a vaccine history actually to see, like, did this person actually have surface antibody at some point in the past, and potentially did it just wane? And then I think ultimately the question that, many of the guidelines are sort of pushing us towards really is like, revaccinate or not. Because you do want to assess what the reactivation risk is going to be if you were to transition someone to a regimen that's not going to be fully active against HPV.
Yeah, so there are some data, there's been 2 studies that I'm aware of that show that if the core antibody alone is positive, that's a very, very low risk. The surface antigen leads to some sort of breakthrough if it's positive in about 10 to 20% of people, and so you don't want to mess with that. But if the core antibody is alone, then the breakthrough is really less than 1%. And what a lot of the hepatologists are now recommending is, and you could keep them on their 3-drug regimen, vaccinate them with, I'll have to use a trade name, Hepaslav, which is a much better vaccine, 2 shots. Get their surface antibody up, because when surface antibody is positive and antigen is negative, that's the best scenario where someone obviously who's been vaccinated, you don't have to worry about they've never been infected, but even if they're core antibody positive, it's probably pretty protective at that part. Any pushback? Yeah, Dr. Thompson.
No pushback at all, but just to add that for that isolated core antibody, if you're vaccinating, we always check the surface antibody titer a month or so after vaccination, and usually the bar is about 10. But for an isolated hepatitis C antibody, we want to get it up to 100, which is easily done with the Hepaslav vaccine.
Okay, so this is the HHS guidelines, and we've already reviewed those. And there's the sort of caveat about greater than 500,000 in hepatitis B co-infection. The IAS-USA guidelines are in sync. In fact, there's a rare situation where there's differences between the 2, and this has gone on for a while. Now, we're going to join Doc Brown and Marty McFly and go back to the future in 2 years from now. I'm not sure exactly how you go back from where you are, but whatever, you got it. Hop in your DeLorean, and now I've just got the story on the right for you again. In this case, the hepatitis B virus is immune. Are there any of these that seem attractive to you? No data, just the idea. There's no right or wrong here, well, there may be some wrong, but go ahead and vote your preference. And let's see if we got music at this point.
No right or wrong, but there may be some wrong. No right or wrong.
It's the time warp.
Is it working?
What is it?
I don't think it's working.
Oh.
Oh, there
There
we
we
go.
go, there we go.
Oh, now. Sorry, you got to keep listening to music and voting.
Now it is.
Okay. All right, so most people are going to stick with what they had been giving. Boy, that 1 year, every 12-month idea sounds exciting. It hasn't quite made it to prime time, or maybe will never make it to prime time with an implantable. Any comments from the panel in general? Tripp, you're going to talk about some of these options. So this is a preview of coming attractions for the last talk tomorrow, the anchor leg.
Right. There, excuse me, a lot of strategies and new drugs in the pipeline to inform our choice here. Hard to beat one pill once a day, right? On the last question, we did have the option to start with all injectable CAB, rilpivirine, and that is outside the guidelines right now. Remember, that's a switch regimen, not an initial regimen. So it's interesting that you brought it in here. I'm not aware that that's being studied right now, but it certainly could be.
Yep. And Dr. Barr, any comment on, you think BNABs for therapy at
I
some
mean, it
point?
didn't even make the bottom of the slide.
I know.
People are not convinced.
It didn't get enough votes to, it got left in the primary. It got primary.
Yeah.
Yeah, it's bad.
I mean, I think that, you know, first, as Dr. Gulick was mentioning, like the barrier to develop virus, or the opportunity to develop virus resistance with a new start and a high viral load is just so much higher than a switch.
Yeah.
That I'm very skeptical that we're going to ever test BNAB therapy for new start, but potentially switch. The BNABs in clinical development right now are better than ones we've seen in a long, long time, but I still think that the clinical trial data we have so far, even paired with LEN, suggest that there's a potential for breakthrough with resistance. So understanding resistance before you start is probably a good approach no matter what, and that would also limit new starts with BNABs.
So you've been involved with BNABs for quite a while, and you know what happens in the background to generate sufficient amounts and quality of BNAB preparations. What do you estimate the cost of a single dose of BNAB to be?
I mean,
Is this Dr.
that's
Evil?
sort
It
of
could
a-
be billions instead of millions.
But that's sort of a silly question, Dr. Saag.
Not
because cost is totally dissociated from the price of production, right? Like, we're not pricing things based on how much it takes to make things.
Correct.
So there's like some magic market value that allows people to price things where they think they can get away with it. So I do think it's expensive to make BNABs at high quality, but I don't think it's actually any more, like, not prohibitively expensive compared to what we charge for,
Yeah.
what we as a society put as a price tag for
So we have
antiretrovirals.
ibalizumab, which is an antibody available now, but it's about 120,000 a year or something like that. But maybe
which
that's
one, I'm
because it's
sorry?
not used that much.
Oh, ibalizumab.
Ibalizumab. But anyway, it's all, you don't think about the cost too much when you're making drugs unless you're a drug company. But I loved your comment. You basically charge what the market will bear.
It's a wealthy country.
Yeah,
I mean, I'm not trying to endorse that.
yeah.
I'm trying to state that that's the reality.
Melanie?
So regarding cost and other issues for BNABs, you know, we've already seen the challenges we run into with long-acting therapies in terms of the burden on the clinic, the burden for follow-up, and so on. And, you know, if you're using a BNAB infusion, you're dealing with infusion issues, scheduling, and so on, and then the subcutaneous injections, which hopefully that is the way they would ultimately be delivered. You know, we still have the issues about burden to the clinic, and that is a cost. And I think we don't think about the cost. Maybe we're thinking about the cost now because we're dealing with lenacapavir and cabotegravir.
Yeah.
But I think
Yeah.
with BNABs, we're going to have additional costs.
Just
Sure.
to end on a positive note, though, the 2 BNAB plus lenacapavir regimen can be dosed every 6 months.
Yes.
Yeah.
We're going to review those data tomorrow. It's
Yeah, we're
pilot
gonna
data,
see that.
early data.
It's just something to throw in the mix. We don't
Can I-
talk about it very much, but it weighs on us quite a bit when we're trying to get treatments for folks. And just look at GLP-1.
Can I make one tiny last comment about the BNABs? Because I really don't want to sort of sell my field down the river in that regard. But what I would like to say is, we had a long discussion about all the drug-drug interactions with lenacapavir. When you're using BNABs, they're a totally different class of action. They're not small molecules. They're not processed through all of our CYP X, Y, and Z. And therefore, the ability to use them without the same types of drug-drug interactions is potentially a huge opportunity for people with many other medical obligations. So that's another bright side of potentially being able to use these very long-acting, once or twice a year type antibody regimens.
As
And I think
Gabby
it's the only
Johnson,
regimen that really does match lenacapavir's long-acting profile, and lenacapavir hasn't had a partner yet. So this is really the first potential partner for lenacapavir.
yeah.
to match
So
it.
as Gabby Johnson would say in Blazing Saddles, harumph. Okay, what regimen should I use in a pregnant patient? So 30-year-old woman presents 6 weeks pregnant. She was diagnosed with HIV 2 years ago. She's on injectable rilpivirine and cabotegravir every 2 months. She's doing very well. Other labs are normal, no medical prior history. This is her first pregnancy. The question is, what do you do? Continue her on what she's on it's just not going to change. Change wouldn't be prudent. Or switch to something else. Check it out and vote.
Evan Hansen.
Okay. All right. So we got a good number of folks who, at least half, roughly, who would switch to, who would stay the same or just increase the frequency of rilpivirine. What say ye? Anyone? Go ahead, Caroline.
Okay, I'll start the discussion. I think if this person was happy and wanted to stay on Cabril, I would be very open to considering that. I can't remember if you shared the date of the last dose, but ultimately I think one of the key take-homes is that the exposure is going to be ongoing for several, for quite a while. And so in terms of the organogenesis, I mean, in some ways it's almost, kind of a moot point. And some of the emerging data that we do have, I think, the favorable safety. And so to me, the question then becomes sort of that next layer of nuance, like how often am I dosing it, depending on if you want to sort of err on the side of caution and offer, transition to monthly, or if you feel comfortable continuing with Q2 month.
Yeah, officially, what do you say down there at the guidelines panel?
The guidelines support that if a woman is suppressed on a regimen, that she could stay on the regimen with a caveat about cobicistat, which we talked about yesterday, that you would have to change because those levels are suppressed. So keeping her on the same regimen is certainly within the guidelines, even though our data on cabotegravir and rilpivirine are incomplete in terms of pregnancy.
So I think from the baby's perspective, cabotegravir is a lot like dolutegravir. It's not exactly the same, but probably
Very
okay.
similar.
Rilpivirine, however, is safe for the baby. We know that. But the levels from injectable can drop up to 70% during pregnancy. So that's really where the risk is, right? So I think it's a little bit of a gray zone, maybe more than a little bit. I think most folks would switch, although you could continue maybe giving it more frequently and checking her more frequently for viral load. If she's adamant to stay, I think you could negotiate that sort of shared decision-making seems to be the theme of the conference. We should put that as a byline. Ryan Warwick Conference 2025, shared decision-making. But, you know, personally, I probably would switch her unless she had strong objection or didn't think that she could take an oral regimen. So this is the perinatal guidelines that say the following drugs may be used if pregnancy on cabrolpivirine, switching to an oral is recommended, but it can be, you know, it's an individual decision, but the reasons not to continue cabrolpivirine is mostly out of concerns of PK, especially for the rilpivirine, but I don't, and we don't have a lot of data on safety in pregnancy, but as long as you can express that, you can go forward. Okay, how about breastfeeding postpartum? A 30-year-old woman delivers a healthy baby girl 2 days ago. She was diagnosed with HIV 2 years ago. She's on a standard pregnancy regimen. Viral load originally 2 years ago was target not detected and remained so throughout pregnancy. She wants to breastfeed. What are you gonna recommend? You know, what are you gonna do? Call Ghostbusters. Let's vote. There could be one option.
One singular sensation.
Could be Marvin Hamlish giving you recommendations. Michael Bennett directed this.
That's correct.
See how many people say some other option. Okay. All right. Thoughts, panel?
It's that shared decision-making thing again.
Damn. I should have just had that as an, and everyone would have gotten it right. Data, anybody? I can go over it, but anybody familiar?
I'll just say at our institution, we have a pretty robust shared decision-making process with our women with HIV who are pregnant, and a lot of them have engaged in breastfeeding, and it's been a really positive experience. I think that there's various levels of anxiety from the providers, but the patients who want to do this, it's such a wonderful opportunity for us to support them to do that.
Yeah, I usually talk about it as the U equals U of pregnancy. The U equals U of pregnancy. It's important that, you know, we tell the mother that if she was virologically suppressed, then it's also a lower risk. And I totally agree with A, that if the importance of that relationship, mother-infant, is such that I would favor it.
Okay. Melanie?
So something that's not mentioned on the slide, but we felt compelled to put it in the HIV primary care guidance, is that there have been issues because of the longstanding caveat about not breastfeeding. There have been issues in which Child Protective Services have been called on women who are breastfeeding their infants, and we felt compelled to put in the guidance, don't do that. Don't call Child Protective Services if someone is breastfeeding. I mean, it was kind of amazing to me because I was not really aware that this was a phenomenon that was actually happening, but so there you have it.
Carol?
Yeah, I mean, I will say that, as you wrote the case, I think that I assume that the breastfeeding interest came up postpartum. I think in an ideal world, these conversations could have, you probably want to give it time. And so if it's possible to bring it up during the pregnancy, prenatal care, that gives you time to document everything, ask mom if she needs anything to address or respond to any potential, scares of CPS, mobilize your pediatric partners. I mean, it really does kind of take a village in some areas. And so we just want women to feel supported throughout this entire journey.
Right. Okay, so this has got an interesting history, this question. So initially, this is even before U equals U, the advice was do not breastfeed, even if the viral load is suppressed, for fear of transmission. And women who are postpartum and breastfeeding who are not on antiretroviral therapy, the transmission to the baby documented negative for HIV at birth can seroconvert up to 6% of the, it's more like 2 to 6, but it can happen. And so that led to those recommendations. However, with U equals U and moms who had suppressed viremia, interestingly, in South Africa and other countries, breastfeeding was so important, predominantly because of two reasons. One, it wasn't necessarily easy to get a hold of formula, and secondly, it was stigmatizing that women who were using formula were sort of felt like they were outing themselves because all the other moms were breastfeeding. So there was a huge push from the patient community, especially in South Africa and other places, to overrule that, and it was successfully overruled. In fact, breastfeeding is now encouraged there. So the U.S. started to adopt that, and I was a big leader of the charge saying, yes, like answer A here, we should do this. Data came in on a couple of exceptional cases that I still can't explain. That there was, I think, one case that I know of, maybe a second case, where documented undetectable virus in mom on every check, yet the baby converted. And no one can explain it, and I can't explain it. And then the question for me becomes, do you let an exception of one lead to a blanket, don't do it? So that's where the shared decision-making comes in. There's a question in the back. Yeah. Come to the microphone.
Can you guys hear me? Is the mic on?
Yeah, you're on.
Okay, perfect. The question is, my understanding with the data is that, yes, the risk is not absolutely zero, and that there's a higher risk with mixed feeding, or maybe I got that wrong, with obviously women who are struggling to make enough breast milk, therefore they're breastfeeding as well as giving bottle, like the mixed feeding, right, with the nipple. And so, therefore, I guess I really love the shared decision-making, but are there educational resources that we as clinicians can give to these women, very not dumbed down, but very patient-friendly educational resources to make sure that they know that the risk is not zero and that those higher risks are there with mixed feeding so that they can make that decision?
Right. So getting together, mixed feeding, et cetera, there are options. Yes, Carolyn.
Yeah, thanks for that question. I mean, I think there are many, maybe this is sort of what Dr. Barr was alluding to. I mean, there are many specific nuanced questions that I think drive some of the ongoing anxiety, and I think the mixed feeding question is one of them. I will say that I'm not aware of any large-scale data in a sort of contemporary ART context that actually quantifies and states explicitly that there is, increased risk. I think some of this information was from sort of just older studies in a very different context, and I think that it's one where we also need to make sure it's clear what we're talking about. Are we talking about sort of supplemental, feeding in the first days of life for a premature baby versus like ongoing, early introduction of solids and things of that nature? In terms of patient information, I think a couple of the sort of centers with larger experience here in the U.S. have thankfully shared some of their protocols and patient materials in some of the publications, and then also there are a number of patient sort of advocacy organizations that have developed some information. But I agree that those are areas that we can sort of collectively, move the dialogue further on.
Okay. All right, and this is where the guidelines, perinatal guidelines say joint decision-making. So we're going to get into the big discussion of what the difference is between joint decision-making and shared. I think shared is more friendly or something. Anyway, the risk is extremely low. I think that's a good take-home point. All right, Dr. Bedimo, coming back at you. 47-year-old woman started Big TAF FTC 12 months ago. Viral load was initially 28,000. Wild type went to undetectable. CD4 count had a nice response. Not only did her CD4 count go up, but her weight went up from 145 to 171, so almost 30 pounds. Her fasting glucose is 101. Her hemoglobin A1C is 5.9. I don't think it measures above 20. It was really, no, it's 5.9. Okay, so in addition to diet and exercise, that's sort of like yesterday's comment, what do you recommend? Continuing what she's on, changing a regimen, adding metformin, starting semaglutide or some other kind of option. Go ahead and vote.
Did you want all the GLP-1s taken off the Medicaid? It's dropped to zero this time, January 1st. And all those,
Sister Act.
Say it.
Sister Act.
No. Okay. Okay, 300 votes, that's our mark. Oh, we got almost half the people going for a GLP-1, and we're going to talk about that later today, among other times. Dr. Bedimo, what you going to do?
I think they're ahead of me, the 44%. So, yes, I think it's two things. One is, do we think antiretroviral regimen should be changed? And I think that you all have said no. And
We said don't do it.
yeah, it's the Do It trial says don't do it. and the second question is, do you want to start another intervention? And is it time to pull the trigger on GLP-1 receptor agonist? And I'm not sure we're there, but I would not disagree with the safety.
Okay. Other thoughts?
The data we have with the GLP-1 agonists in people with HIV is pretty slim. There was one study presented at the IAS meeting that showed it worked while you took it, and then when you stopped it, the weight gain came right back.
And that's true for
And it's
all
true
people.
for people without HIV
Yep.
as well.
But thank you for bringing that up, Gillig, is that another thing that I want people to be very aware of with GLP-1 receptor agonists in people with HIV is that most of the weight loss is fat mass, but there is a substantial amount of lean mass loss. And you will lose muscle, especially, unfortunately, for older people. So who may already be dealing with concerns with frailty. And so losing muscle mass is not a trivial thing. Just be mindful of that.
So that underscore the caveat at the top, diet and exercise to keep lean muscle mass together. That's kind of a requirement. Other thoughts, Hyman?
Yeah, we were just talking about this at least in California, all the GLP-1s are being dropped from Medicaid, or Medi-Cal, which is our public health insurance. So as of January 1st,
For an
everyone.
obesity indication.
Yeah. And so most, I'd say half of my patients who are on them are going to lose access unless they're having to pay out of pocket. So it is going to change with all the shifts in health insurance, what we have access to for our patients in many places. But yeah, I'd say probably half of my patients are on one of the agents.
Yeah, so that is an issue. The reason I put metformin in, because metformin works for some folks, and that's not a bad place to start. And some insurance plans require a start, attempt, and failure of metformin to achieve goals before they'll approve a GLP-1. But I think you're right. This is going to become more of a battle. Health insurance plans, not just state Medicaid programs, but a lot of the private insurance companies have found that GLP-1s have become the rage, if you will, and a lot of people are on them, and the prices really haven't come down. It's hard to imagine that those drugs cost that much to make. Of course they don't, but they charge what the market will allow. That is, seems to me that companies set prices to get to a point where they can get by without people screaming. And then they advertise on TV so you don't scream as loud. So you really want that drug. Yes.
This is picking up on Dr. Bedimo's last lecture about don't change. I think many of us are not satisfied with that because you put the patient on this medicine, she gained 30 pounds, and you're like, just keep taking the medicine. There's nothing else to do. So that seems insufficient. I've heard you talk about data that I've seen in clinic with TAF especially for minority women and significant weight gain on TAF. So I wanted to just revisit the question of changing her, right? You put her on this medicine, she gained 30 pounds, and you're like, okay, now start this other medicine. And so I think realistically in clinic, we need to be able to do something else, and most of us are not comfortable keeping that medicine going, especially if those of us who are seeing, minority women who gain a lot of weight with half. So I probably would have switched her and started the GLP.
Yeah, that's a great point. Roger?
Yeah, I wouldn't disagree with you, except that we are bound to follow the data. And so far, like the table I presented to you of all the switch studies and their outcomes, have really shown that the large majority of studies did not show any significant difference in weight trajectories with antiretroviral switch, even switching away from TAF, even switching away from INSTIs. Now, the reason I put that caveat there in that table with the duration of antiretroviral regimen prior to the switch is my own bias by thinking that when I know since the NA Accord data 5+ years ago to any other data that you want to see, if somebody's going to gain weight on an antiretroviral regimen, it's usually going to happen in the first year, even the
First 6 months, really.
even the first 9 months.
Yeah.
So that being the case, and knowing that many of the curves of weight trajectory will be plateauing or almost plateauing after that year, a change at that time may or may not be useful, informative. So I agree with you. In our clinic, I would see that. Let's look at what predicts the weight increase. We don't know much. We know that if you are non-white and if you are a female, you're more likely to gain weight. Beyond that, we don't know a whole lot. So you can't tell someone that this is your likelihood of gaining weight when you start. I wish we could, but we need to come up with biomarkers. The second thing is, in the trajectory of weight increase, if that person was to come back in 3 months and I had something that I can tell me they're on the wrong path, maybe at that point, any change would matter. So yes, I think, can I change? Would I consider changing a person at a year that have gained 30 pounds? Yes, I just know that I am not standing on solid evidence.
Yeah, so I think your point is extremely well taken, that the patient has associated taking this particular drug with that weight gain, I mean. And so to say, I'll stay on it is not very satisfying. So there's nothing wrong with switching, if nothing else, for peace of mind of the patient. But for you as the provider, don't necessarily anticipate that the weight's going to come down. If it does, great, but it's not going to be likely, so you need to be planning for other options, and I think that's the take-home point. But great points. So discordant CD4
Mike,
will go.
can I say one real quick thing?
Katie.
Oh, I just say, I personally feel like in my HIV clinic, weight gain and all of the, associated issues with that, especially with sort of African American women, which is a huge part of my clinic, is an enormous issue. And clearly the data show that all weight gain after antiretroviral therapy is not the same. One of the conversations I like to have with patients that I think is a little bit helpful is to think about sort of what was their weight before, if we can project, we think that the sort of catabolic state of advanced HIV started. And so if we can get a sense of sort of what their normal baseline weight was, and then sort of think about the weight loss that they had as there was a lot of inflammation and advancing disease, and then when we start antiretroviral therapy, there's this return to health, and we switch to an anabolic phase, and we kind of go back to what our body's set point was, and that helps us think about sometimes the difference between healthy weight gain and, we know, inflammatory weight gain, unhealthy weight gain, but that helps sort of process with very challenging issues about, I just gained 30 pounds in the past 6 months.
Right.
So we can choose medicines differently, I think, in those patients who are starting antiretrovirals to try to limit weight gain, and then have the discussion about what is likely associated with antiretrovirals, what is part of our bodies being able to gain weight where we previously weren't.
Yeah, I think I'm going to need to move on, I think, because I've got a bunch of other things we can talk afterwards. Yeah, but yeah, the point is good. So one thing I think somewhere in all this is a scientific question that's begging to be answered is that There's something that A, causes that we don't understand, and there's something that GLP-1s do that sort of change that, and I think that pathway may be similar, if not the same, so that's worth doing. 30-year-old woman comes in on TDF, FTC, and boosted darunavir, started 4 years ago, good response. She's tolerating well, but the CD4 count still hasn't made it to 200. What are you going to do? Change your regimen? We ask this question a lot. I bet the majority get this right. Answer D is kind of interesting. Go ahead and vote.
It's definitely add IL-2.
Funny girl.
Barbara? Or Leah?
No, it's Barbara.
Okay. So most folks have been in this rodeo before. It's interesting. Anybody? The bottom line is that it's a biologic phenomena is a take-home point, and there's nothing about the viral load or the ability to suppress virus. It has to do with a release of CD4 counts, CD4s from inflamed tissue, especially lymphoid tissue at the time of initial treatment. That boost that you see in the first 2 to 3 months is there because of that release. Think of demargination with steroids and leukocytes, same idea, sort of. But the take-home point here is that it doesn't really change things. We're going to talk about this in the breakout I have later today, but fostemsavir has been pushed as a drug that increases CD4, but when you look at the studies, there are studies of people who had virologic failure, the virus came under control, and the CD4 count went up. Yeah, we've seen that since, Fibber McGee. That's not a new thing. But when you look at people who are suppressed already, and then you add fostemsavir, it doesn't change. So that's not a reason to use that drug. Michael, real quick.
Yes. It's clear that she doesn't have a viremia problem, but I was one of the people that voted 1% for something else. Just early days of my work at Stanford introduced me to the use of N-acetylcysteine in these patients to see if they have a glutathione deficiency. And it's a way just to start to see if this would make any difference. 6 months of it can make a difference, and if it doesn't, then it doesn't. But it's been very useful for some patients.
Yeah.
Just something to think of. I don't know if anyone else has any. You were shaking your head, Roger.
No, I do agree with you. I remember
Herzenberg lab did all this work at Stanford.
There were Esprit, Silcat studies that tried to increase
Silcat.
your CD4 count by IL-2. Okay, nothing works, and so let's not try anything. The good message is that this person's risk of OI is virtually zero.
Yeah. It's the
It's
virus.
really, really important.
Correct. It's the virus that causes the immune suppression. It's taken us about 30 years to figure that out, but the data are there. It's not a CD4 count phenomenon. Maybe we'll talk about that with the OI cases. Yeah, Trip?
One other point to make, you didn't tell us what our starting CD4 is, but it was likely to be quite low. It just
was like 80. I had it.
Oh, it was 80? Okay.
Yeah.
It just reinforces that although we don't understand this discordance, it's people who start with low CD4s who tend to not be able to boost it.
I think it's sort of explained here to a point. This is what you normally see when you start antiretroviral therapy, but notice that most of the bump is in the first 6 weeks to 12 weeks. And in these folks, in general, they don't get that bump. And there are data that show that in inflamed lymphoid tissue, like lymph nodes, if you go pre-therapy, 3 months post-therapy, inflammatory markers and adhesion molecules inside the lymphoid tissue, ICAM, VCAM specifically, are markedly reduced. And ICAM and VCAM are those things, think about like them as flypaper that cells latch onto. You take that away and the cells go back into circulation. And I think the reason that we don't see that with people with low CD4 counts at baseline is because their lymphoid tissue and their architecture has been disrupted. And we can't fix that unless we do a lymphoid transplant, which doesn't exist, so forget that.
So more of a reason to start earlier like we are doing today.
Yes. Harumph. Okay, so what therapy should I use as initial therapy in the setting of PrEP failure? Dr. Scott, we're going to turn to you, 28-year-old newly diagnosed, had been on CAB every 2 months for PrEP, had not missed a scheduled dose, last dose 2 months ago, asymptomatic, diagnosed by what you recommended yesterday. On viral load testing, it's low, confirmed positive, but definitely detectable, CD4 count 850, labs normal renal function okay to start therapy. What regimen would you choose? And I know the answer is going to be it depends, but in general, what might you pick to start with? Go ahead and vote.
Hairspray.
Okay. All right, so most people would use a boosted PI here. Anything in the story that makes you think that resistance is more or less likely, that it sort of happened without missing doses as opposed to missing doses?
Yeah, in the studies where we saw these sort of very rare breakthrough infections despite on-time dosing, it was particularly 1 or 2 additional doses after the look back to see when the acquisition actually occurred that really drove the development of resistance. So for this person, I'm not sure how long they've been on CAB.
Let's say 2 years.
But yeah, this is someone who may have, because you do see Levi with cabotegravir long-acting, it is quite possible that they have been had a low smoldering infection, received subsequent doses because it wasn't detected, and now have high-level resistance to the integrase. So these are exactly the cases where you would want to use a boosted PI until you can have a genotype to document that this wasn't a sort of delayed diagnosis, which is the scenarios where you really see the resistance developing.
That's a perfect answer. Thank you. That was what I was going for. Okay, so hopefully everybody followed that, but the take-home point is that you're going to start with a PI-based regimen until you know you got the resistance test cooking, but in this particular historical setting, it's a little bit like the RPR yesterday with Dr. Ghanem. You need to know the clinical history as well as as long as the lab data, and you described it well, this Levi syndrome that isn't picked up, that basically means low-level viremia. And somebody who's picked up infection, you don't detect it with the HIV RNA. Initially, you do a look back, and this is smoldering, and then you end up having a resistant virus. Okay, just says, in the guidelines to check for resistance, yep. Okay. So similar, let's go on to, in the treatment story, cabrolpivirine regimen failure. 38-year-old person with rising viral load on cabrolpivirine had been on Big TAF FTC previously with target not detected, switched to cabrolpivirine, ultimately going to every 2 months after the lead-in. HIV detected by routine viral load confirmed. CD4 count 850. Resistance testing shows 2 mutations associated with cabotegravir. You can go to the IAS-USA website and pull up the mutations chart updated just recently. So which regimen might you choose here? Go ahead and vote. Not throwing away my shot to treat this.
Exactly.
Thank you, Lin-Manuel. Okay.
Nice.
All right, again, most folks went with the boosted PI. Anybody, let's talk a little bit about maybe lenacapavir use here. Folks excited about that? Can you use it? Is it reasonable? Would you use oral or injectable? What you going to do?
Guidelines support what the audience said.
Okay.
Go to the boosted PI. Lenacapavir is currently labeled for multi-drug resistant HIV, which this person does not have.
Yeah.
And the other problem with the choice here is you're giving lenacapavir with a daily oral pill, and that may be a problem.
Yeah, sort of mixing and matching and that type of thing. We have oral lenacapavir available, but its half-life is substantial, and you'd have to dose it a little bit less frequently. How about twice-a-day dolutegravir.
So that worked in the time when people were failing either elvitegravir or raltegravir and hadn't selected out the pan-resistant mutations, but Mike showed us this person has 2 pan-resistant integrase inhibitor mutations. So they have knocked off the entire class.
Yep. Well discussed. Okay. So what to do in a setting of persistent virologic failure and a history of poor adherence? 34-year-old guy, frequent meth use, transfers from another clinic, lots of prior regimens. You can look at them there. Intermittently had viral load less than 200. And no toxicity to or AEs, but only documented resistance is M184V. What do you prefer at this point? Here are your choices. Go ahead and vote. Still in Act 1 of Hamilton.
Yeah. Greatest city in the world.
Yeah, some people say that. Everything is legal in New Jersey. Okay. So got with detectable viral load going to cabrolpivirine. What say ye all? What would you tell them, Carolyn, if you're on the warm line?
I mean, I can see the appeal for what the audience chose. I mean, this person has tried 3 different oral combinations and just didn't sort of stick with them or didn't work for whatever reason. And I think if you're confident that the M184V is really the only mutation, then that is not, Cabrol would be okay.
Yeah. Hyman, you guys, both of you actually are in San Francisco, so, or, yeah. So what do you guys were some of the pioneers with using cabrolpivirine even with detectable virus?
Yeah, I think with, very close monitoring, I think these are exactly the types of patients that we wanted to try to offer them something that better fit for them to be able to become virally suppressed and sustain that. And I think that it showed success. There were definitely some risks of virologic failure, so very close monitoring. This is someone who you might want to keep on monthly, potentially, depending on how, their social situation is, particularly if there's any risk of like them becoming unhoused and a variety of other factors. But it definitely comes with a little bit of concern and some consternation, but the patients, when they're able to finally remain virally suppressed, has been transformative for them. And I think that has really been one of the other motivators, that we aren't doing harm. We're helping to keep people virally suppressed, and their experience doing so is, for the first time in their lives, oftentimes they've been persistently virally suppressed.
Okay. I think, Melanie, you wanted to say.
Yeah, so, and I would say now that this is guideline supported, and, for people who are really at high risk of HIV progression and death, and who have tried to take other regimens with support, just can't do it, particularly those with low CD4 counts, then I think it's incumbent upon us to do what we can to try to help these people. And this has, so that prompted an IAS-USA addendum to the guidelines, basically laying out these criteria for who is a good choice. Now, the guidelines really are focusing on those people at high risk of progression. They're not focusing on people who are viremic and, they're have a lot of other options. So that's where the guidelines are at this point.
There's a
So
study
thanks
out.
to the,
HHS
thanks to the
as well.
people from San Francisco, we now have the latitude.
Yeah, Atlanta even
this.
had a study. Yeah.
Well, there is one concern, though, here, and that is he's been on rilpivirine before, right? And so he could have NNRTI resistance that's not showing up on the tests today. Attractive regimen for him might be cabotegravir lenacapavir, which there's limited data on. It's really anecdotal data, but it's about to be tested, but that might be a good choice for him, because that would be 2 new classes, essentially.
So all the above. So these are tough cases. They're meant to be challenging. That's why I put them in here. I think well, we're going to get to use of DNA testing in the next case, I think. But this is what the guidelines, HHS guidelines say. Okay, what do I do with the patient who has a cellular M184V? So here's the story. 65-year-old guy transferred to your site for evaluation. 28 years ago was diagnosed with a high viral load and a low CD4 count, treatment failure from multiple regimens for toxicity, now is on dolutegravir 3TC and abacavir. 14 months ago, prior to his transfer, he got consolidated to dolutegravir 3TC. It was a reasonable thing to do. Viral load is still suppressed, although not undetectable technically. CD4 count's fine, no historical resistance test. And during the routine visit while you were out of town, your colleague covering for you ordered a DNA genotype and it revealed an M184V. What the do you do this time? Let's go ahead and vote. Not gonna debt. Let's go ahead and vote.
See how many people order A.
I want to see how many people answered D.
Fire your colleague.
What if that colleague is your boss?
Okay. All right. Damn. Yes, 8%. None. Great. Keep going. All right. So comments here about DNA genotypes. Popular. We should have had that song.
I mean, I think in this scenario, that didn't tell you any new information than you probably could have gathered just from the clinical history that you shared with us. And I think there's some emerging data saying that if it's just an M184V, actually people will likely stay suppressed on this regimen.
So there's a lot of things to unpack here, but the reason I gave this case is because I get a lot of questions in more complicated even situations than this that say, I want to use a DNA genotype because I don't know. And the answer is, it doesn't give you the answer that you hope it's going to give you. And this paper that just came out about 8 or 9 months ago from the IAS-USA resistance panel summarized it as well as you can get. So this is, if you're thinking of ordering that test, this is a must read. And it's complicated, but they explain it well and clearly that a lot of viruses that are inside of cellular reservoirs, as Dr. Barr has told us yesterday, are defective, or they have stop codons, or they have ApoBec3B, 3G. Yeah, and they have things that interfere with your ability to know if what you're getting is real, or is it just an artifact. And this panel, I think appropriately said, it's most likely an artifact, so you're sort of reading Braille when you don't know how to read Braille. You know, it's not telling you what you think it's telling you. So it's really not as helpful. And the only thing that they say, this is my take, boiling it down, is that the only thing that it really tells you is what subtype the virus is. That's reliable. And how often do you use that in practice? Never. Okay, so that's kind of the point. Dr. Barr, do you ever order this test now that I've dissed it?
I mean, almost never. I genuinely find it to be insensitive and nonspecific.
Yes. And,
I mean, it's not that I
and
genuinely
you're a
find
reservoir
it.
expert.
The biology of the reservoir is we are looking for many viruses within, or a small number of viruses within cells distributed throughout the entire body, largely in tissues, and a few of those marginate into the blood, and then we sample an even smaller number of those, and then we're asking a test, which probably appropriately assesses the blood viruses that were given to it, to be able to then infer the entire phenotype of the rest of the body. And it's just physiologically not possible because we are so substantially undersampling the entire reservoir. We also know the reservoir changes over time such that defective clones are much more likely to expand and be the dominant thing that we sample, but not the phenotype that actually drives virus that can reactivate. So I just complicated things, but I would say, yes, it's very rarely useful.
So I wonder in Austin Powers whether Mini-Me was a defective clone. I don't know, just wondering out loud. The other part about this story, that's important is he's been on that regimen for 2 years and the virus is still suppressed. You don't need any more data, so I'd fire your colleague. Yes.
On topic, I was thinking about this during Dr. Scott's case of PrEP failure. Since the viral load was so low at baseline, would you have thought to do this in that situation? Because in the absence of an INSTI mutation, that could open up a whole class where if you don't have that information, you would potentially never use it.
I mean, I actually think in the setting of recent infection, and again, the question we were talking about here, we were unsure how long how long ago they may have acquired HIV, and people with, Levi and other early antiretroviral therapy situations have very small reservoirs, but the reservoir is likely to be homogeneous, such that if you're able to sample any of that virus, it's likely to be predictive to all of the viruses, as opposed to long, after much virus replication and much time on ART, any one sampling is unlikely to predict the rest of the reservoir. So in recent acquisition or very early antiretrovirals, you may not get an answer from a DNA test, but if you do get a sequence, it is likely to predict the rest of the sequences.
Yes, that's an outstanding question. The point is exactly that. So the reason that the reservoir virus is so complex after 20 some odd years of therapy is because it has time to accumulate all these defective viruses, and early on it doesn't. Fortunately, the situation of PrEP failure leading to a viral load that's under 200 at the time the person is diagnosed is not that common. And most of the Levi was in lookbacks, right?
Yeah.
And then later come up, and I think we addressed that earlier.
I think the only time I probably sent a DNA was in a scenario like that where you had a positive antibody antigen, concern about this being a real new infection and an undetectable viral load in someone who is on an injectable but also taking TAF FTC from a friend. And so they had all this exposure because they had missed a dose and were taking this to cover these missed doses, and then and it wasn't ultimately useful, but there was
it didn't read?
Yeah.
Okay.
Yeah.
Good.
And so those are like the very rare scenarios in which this is useful.
Okay. So the last case is a case I've been managing the last 2 years, and I don't want to spend a lot of time on it because we've got 13 minutes left, which includes a Q&A, so I want to got a lot of questions on Slido and elsewhere I want to get to, so I'm just going to fly through it just to make the point I wanted to make. This is a real case, 35-year-old guy diagnosed at this time that I wrote the question a year ago, who came in with fever, chills, anorexia, weakness, etc. He had PJP and MAC on a lymph node biopsy, got treated appropriately, treated with antiretroviral therapy, trimsulfa, azithromycin, rifabutin, improved, and 6 weeks later had a post-discharge recurrent fever, diagnosed with IRIS, treated with steroids, improved. Standard stuff so far. Then about 6, he gets lost to follow-up and then staggers back into clinic, restarted his meds, felt better initially, but now has fever, anorexia, abdominal pain, constipation, viral load suppressed because he restarted, but he went for a while off of all therapy. White count was elevated with a left shift, with fever. CT had lymphadenopathy with necrosis unchanged from original lymph node biopsy, showed numerous AFB that were negative for malignancy. Blood cultures and lymph node cultures were unrevealing at that time. And I'll just cut to the chase, we won't vote. This was recurrent MAC. I initially thought it was recurrent IRIS, but the trick here was to take those lymph node biopsy and culture the AFB, and it turned out that not only was the AFB positive, it was mega resistant. And it was a huge clinical conundrum. We had to put him on amikacin and some other almost investigational MAC drugs. Fortunately, he maintained his hearing after 3 months of amikacin, which is a huge concern. Those of you who were not part of the early days of treating HIV remember patients, I know too many, who, despite assiduously measuring amikacin levels and keeping them in range, still went deaf. So that's doesn't seem to be a dose-associated complication. Renal failure, perhaps, but not hearing. And that once deaf, always deaf, and it didn't come back. I was very nervous about that. Worked with a mycobacteriologist at UAB, and we got him through it, and he's, knock on wood, doing really well right now, but it took a heroic effort. And the hard part was diagnosing the recurrent MAC with the resistant bug. So, yeah, yay, you got it right, 24 of you. Okay, so just concluding, and then we'll finish up here with questions. ARV therapy should be initiated with an NSTI-based regimen. You guys knew that. Weight gain we talked about ad nauseum. Semaglutide, there are increasing data. Phoenix has a couple studies now, I think one that'll be at Croy and a couple of others, but it really does work. But your point, Trip, about weight coming back is true, and that's true for a lot of folks, whether or not they're a person with HIV. Dolutegravir and BIC are regimens of choice now. Breastfeeding's okay with shared decision-making. Rilpivirine is okay in people with HIV who have trouble with adherence to oral medicine, but with the caveats of all the things we talked about. Treatment discordant CD4 counts, a biologic phenomena. Changing the regimen doesn't make a difference. Cellular DNA in general is not terribly helpful. Let's go to some questions. So I'll moderate my own questions here, but I'll turn it to the panel. How do you navigate infant prophylaxis and testing with breastfeeding? Yep. Carolyn, go ahead.
Okay.
Yep.
Couldn't hear the question.
Oh, sorry.
I'm sorry.
How do you navigate infant prophylaxis testing and breastfeeding? Go ahead, Carolyn.
So yeah, I mean, I think we're fortunate in the U.S. that we actually have a number of options available to us, and I think there are really different contexts that you would need to make this decision. So if we assume that someone was suppressed throughout pregnancy, really committed to staying suppressed postpartum, then ultimately we can choose sort of lean ARV prophylaxis options or potentially none. Actually, you know, this is sort of part of the shared decision making. I think in the U.S. we've got the most experience with nevirapine. I think there are data to support 3TC, but where it comes into play, I think, is sort of the duration of the ARV prophylaxis, because with more meds comes more monitoring. With these infants, you're generally doing, you know, testing on a pretty frequent basis, and you want to coordinate that with mom's testing. So to me, it's just part of this, you know, comprehensive discussion about, you know, the infant's care.
Okay.
The one thing I say is this is not available now, but this is the perfect opportunity for a long-acting BNAB for an infant prophylaxis in the setting of U equals, you know, a suppressed mom who's nursing. It's just perfect.
Go
in so many ways. Go get it.
Yeah. All right, so we got about 8 minutes left, so I'll try to get to 8 questions quickly. So one question is about rilpivirine concentrations if oral therapy is used as opposed to injectable, and in general, that's okay, right? That's an approved regimen. It's that rilpivirine commentary that we had was related to the injectable. Okay, which of the following ARDS are better for hepatitis B? Anything tenofovir-based in general. If you use 3TC alone, you can get, after about 20 weeks, resistance or FTC, and you'll get it, and that won't be helpful. So you need to have tenofovir with it, and usually with the 3TC or FTC, is the rule of thumb. When do you stop breastfeeding, and at what viral load level? So if somebody develops, I think it's like virologic failure. Any thoughts on that? So somebody's up breastfeeding, they're stable, and then suddenly their viral load creeps up.
Oh. Okay.
Go ahead, Katie.
I mean, I think the guidelines now are for 6 months, regardless of viral load, and certainly if the viral load creeps up, that needs to be a major discussion point and/or consideration for stopping. Like, it's the current guidelines do not support viremic mothers nursing.
Yeah, and I'll just add, I think the sort of intensity of the intervention that you're going to offer is going to depend on what that viral load is. I think, viral load of 52 may not cause as much concern if you're seeing like 200 plus. And yeah, I mean, so I think the 6 months was sort of to harmonize with other guidelines, but, we have heard on the hotline cases of people, of breast, fed infants well past 6 months, and I think we need to address our anxiety that we feel, but again, mobilize all the support, really talk with patients about what it is that's going to help, make sure that they do stay suppressed.
Shared decision-making. Okay, so I don't know, any question about, sorry about the trade name, Hepaslav, the Beehive study. The question was about, does that vaccine work in people with HIV? Answer? Yes. And in fact, up to 6% with 2 doses in your group. Dr. Marks was the leader of that study.
Author.
Right.
Just got named one of the JAMA Best Papers of the Year.
There you go. So that's one to look up. But yes, that vaccine is spectacular in that setting. For viremic patients interested in switching to rilpivirine, is it recommended for monthly injections and then for a couple months and then going to every 2 months? Yes.
Yes.
So you don't want to start with every 2 months. You really want to go monthly. I would personally go monthly until undetectable, not to torture the person, but that way you're sure you got it under control, and it usually comes down pretty quick.
Mm-hmm.
Yeah. Okay. And the LA CAB failure for PrEP, CAB failure for PrEP, where viral load at baseline is very low, less than 500. Genotype, we talked about this already, about resistance. What do patients with viral loads in the 100 to 200 chronically on effective treatment with no mutations against the regimen, assuming you can get them, is that drug failure like 120?
So
you want to go ahead?
Oh, you go.
I just think, so there's increasing evidence of this phenomenon, in particular of people who've been on antiretrovirals for a long, long time, where their reservoir expands. They potentially can have these larger expanded clones. It may be defective virus, it may be replication competent virus, but the antiretrovirals are continuing to work. They are blocking ongoing virus replication, but they can have expansion of clones that spit out a little bit of virus that can be detected on viral load assays. So you may have a patient who's been undetectable for years, and then they start to have a little bit of viral load and then a little bit more, and even up into that sort of 100s range can be full suppression of replication, but these sort of expanded clones spitting out virus. So you still have to go through the same thing, make sure you're not taking any vitamins or minerals, blocking absorption, making sure they're adherent, making sure there's no other changes that you may think may be preventing that good antiretroviral suppression, but you can see this sort of virus sort of low level increase even, and we shouldn't be too anxious about this. In terms of the person's progression, if their CD4 count is stable and they're otherwise doing well, this is a more and more well-documented phenomenon.
Yeah, and typically the people that have low-level viremia chronically that don't go less than 20 are people who at baseline had 1 million copies, say, before you treated, and they have a larger reservoir to start with. The other thing, and this will go into in my breakout session, but sometimes people will start antacid therapy or some other divalent cation that can interfere with the INSTI, but then that keeps rising. But the general rule of thumb is virologic failure is defined as 200 or above consistently. So it's a little bit strange to see 135, 145, but most people would not call that failure.
In as many as 5% of patients, so it's a common phenomenon.
Right. Dr. Bedimo, are you as taken with the weight gain story that if you take one of the folks like you described who is at high risk of gaining a decent amount of weight after starting, do you go as far as to not recommend an integrase inhibitor and TAF up front? Would you use an NRTI like doravirine, TDF, and FTC?
Yeah, I will be departing from the guidelines. So it's clearly stated in IAS-USA and the DHHS that we should not consider the likelihood of weight gain in antiretroviral choice. So let me put that as a caveat. That said, it's important to address the likelihood in populations that are so much more likely to gain weight, and that is female non-white. And so while a significant proportion of that weight gain could be the return to health that Kerry said, but it's still a problem that we cannot predict. We just know that is the demographic, and I cannot say choose something different because of that, but since we have 3 different regimens now in to oral, so you, and one of which being a dual therapy, that may be something that you want to consider and as initial antiretroviral.
So it depends. Yeah. Okay. So the final question is one that I think we have. I just lost the question. It had to do with what to do when the viral load is stable, but you're trying to, I've got too many questions, sorry. No, not that. Oh, yeah. So you've got somebody who has viral suppression to a good degree, but the CD4 count is in the 100 to 200 range. What do you do with prophylaxis for OIs?
You don't.
And let's say it's 6 months. It's been that way. It's not going up above 200. Is there a point where you stop prophylaxis?
Yeah, I think that between CD4 count between 100 and 200, there's more data that the risk of OIs is very little, if any, and that it would be safe to discontinue prophylaxis. The reason we don't say the same thing with CD4 count less than 100 is because there's less data. But the fact that people with discordant responses who have maintained viral load suppression, but CD4 count has not appropriately increased, either primary or secondary immunologic failure, there are different names for that. Why don't these people develop OIs? Also to consider whether we actually do understand what leads to OIs.
Well,
because it's too unsophisticated, we only count cells.
Yeah, so what I would say is that the virus is really the immunosuppressive driver, and that when you have low CD4 count and a high viral load, that's when trouble happens. You drop the viral load and good things happen. And in that back-end way, IRIS is a great example of the immune system responding to the absence of virus in that setting. You had a occult infection you didn't know about, you drop the viral load, and here it comes expressed because the immune system wakes up. And that another question to ask is, how many people that you have in your practice who've got, in that setting, have a suppressed viral load and 6 months later develop new CMV? Doesn't happen. Or new MAC? Doesn't happen. Or even, well, crypto could happen to anybody, but you get the picture. So it's a virus, so at some point you definitely can stop, and that's a good question for Dr. Mazur tomorrow. We'll go ahead and wrap up. Thanks to the panel, and thanks to the audience for great questions.